Good afternoon, everyone. It's a pleasure to be here. My name is Marcello, and I'll be giving you some early results of my clinical PhD study where I was exploring the relationship between cardiac pathology and pulmonary tuberculosis, and this is in Lusaka in Zambia. So as we've heard a lot about today, we have an increasing link between tuberculosis and cardiovascular diseases, and this is important because cardiovascular disease burden is increasing across the world. But our understanding of the underlying mechanisms and how these might differ across sub-Saharan Africa is still relatively limited, and there may be a greater proportion of patients who have pericardial or myocardial disease. And this is what I chose to focus on within the clinical study in my PhD. So, very simply, this was a consecutive cross-sectional study where I recruited patients presenting to an outpatient facility in Lusaka with bacteriologically confirmed pulmonary tuberculosis, matched on a 2-to-1 basis to comparators who did not have TB. They underwent a clinical assessment. They've had blood tests that have been stored for BNP and troponin, as well as CRP, and then a point of care and a transthoracic echocardiogram to detect cardiac pathology. The primary endpoint was cardiac pathology, and the three key endpoints within that was pericardial effusion, at least mild left ventricular systolic dysfunction, and/or any evidence of constrictive physiology to determine a prevalence and explore risk factors that might be associated with that prevalent cardiac pathology. Those patients with bacteriological TB get followed up at 2 and 6 months, and assessments are repeated at the end of 6 months. And here, the aim is to look at the natural history of cardiac pathology over the course of pulmonary TB treatment. So today, I'm showing you some early results, and this is confined to the participants with pulmonary tuberculosis. So since November 2023, I've matched my sample size of 250 participants, and you can see from Table 1 that these broadly, I know that they broadly reflect the local epidemiology of patients who are predominantly male, young, who present sick with prolonged symptoms, and in terms of cardiovascular risk factors pre-existing, I've listed their hypertension as the only one that was important other than any history of smoking within the TB population. And now I'm going to show you some summary results of the echocardiographic features of the first 222 participants with pulmonary TB. So when we look at these, the headline result so far is that any cardiac pathology is present in 41.9% of participants so far. And I've highlighted as well the HIV, the proportion of patients who are living with HIV, just to highlight that this is quite similar to the rest of the population within the cohort. As you can see from the distribution of CRPs, and again, I stress these are early results, and they're mostly, they're entirely descriptive at present, but there's a nice, there's raised CRP across the entire cohort, and this seems to rise with participants with cardiac pathology, which would be expected. When we look more closely at the distribution of cardiac pathology within these patients, I've selected here in red that cardiac pathology which would be considered clinically relevant, so a pericardial effusion of greater than 2 centimeters in depth, at least moderate or severe left ventricular systolic dysfunction, and any evidence of definite constrictive physiology. And as you can see, the proportions are quite high, particularly for systolic dysfunction and constrictive physiology. But again, I think it's important to note that for those few patients where I found a very large pericardial effusion, this is in the context of patients with otherwise diagnosed with pulmonary TB, they went on to receive adjuvant steroid therapy that they wouldn't have otherwise received. So that was important certainly to me. So in terms of interim conclusions, at this point, in terms of the cross-sectional data, I think importantly there was a study from the Center of Infectious Disease Research in Zambia from my colleagues there who have reported a similar rate of cardiac pathology in their patients with pulmonary tuberculosis. So far I haven't found any differences within the group according to gender or HIV status, but again, these analyses are very preliminary. I think it's important to highlight that clinically significant cardiac pathology was found in 1 in every 5 patients, and it will be really useful to have the comparator analyses soon to establish a true prevalence across a local community in Lusaka, and obviously look very, very closely at significant potential confounders in this cross-sectional study. And I think I need to highlight just how sick the population was that I was looking after and how deeply malnourished they were when at recruitment as well. And these are obviously going to be very important confounders to look at. Soon, very soon, I will have cardiac biomarkers, troponin and BNP, and then later on I'll be looking at proteomic analyses, which I really hope will enrich this data and inform us a little bit better about what kind of mechanisms might be underlying the relationship between TB and cardiac pathology. And I thought, as a final slide, how this might be relevant to post-TB disease. I wanted to highlight again that a significant proportion had evidence of constrictive physiology, and this constriction is potentially responsive to adjuvant treatment if we think about steroids in the context of pericardial TB. Finally, again, I'm going to highlight just how sick this group of patients was, and I'll be really interested to see outcome data in terms of TB outcomes and mortality. My study isn't powered to look at that in terms of outcome assessment. However, I think it may be informative in terms of looking for patients who might be at greater risk of post-TB disease. And I'd really like to thank everybody at Zambia for helping me set this up, all of the patients and all of my team who've been helping me along the way. Thank you.